So beyond BRAF, the next largest genetically defined subset of advanced melanoma patients are ones with an NRAS mutation. So just to emphasize that unlike more common epithelial cancers that have KRAS mutations, in melanoma it's NRAS, that's the one that's mutated. So 45% of patients have V600 BRAF mutations, but 20 to 25% of patients have NRAS mutations. So it's a distinct genetic subgroup and our next largest one. So it turns out, as I think many people in this audience will know, RAS and RAF essentially communicate to each other. In other words, activated RAS signals through RAF and the MAP kinase pathway, but notably RAS also signals through other downstream pathways, most notably the PI3 kinase pathway, but there are additional ones. And so we've wondered, in a disease like melanoma, where BRAF mutations are featured and where MAP kinase pathway signaling is so prominent, could it be that these NRAS mutant patients also have MAP kinase pathway dependence, quote unquote? Turn that around to therapy. What we were interested in is whether MEK inhibitors, not BRAF inhibitors, because BRAF inhibitors turn out to not be able to block the pathway in RAS mutated cancers. That's been shown unequivocally in the preclinical setting, and really no one's ever tried using those drugs clinically. But MEK inhibitors are a different animal, and we've been very interested for years now that they might be uniquely useful here. Phase 2 data shows about a 15 to 20% response rate with a MEK inhibitor. There's several MEK inhibitors that have shown those response rates in NRAS-mutant melanoma. So the NEMO trial was launched as the first phase 3 trial to test a MEK inhibitor monotherapy, binimetinib, one of several that are in the investigational group of drugs, versus historically standard chemotherapy, dacarbazine, in patients who are either treatment refractory or increasingly commonly patients who have been treated with an immune checkpoint antibody and progressed. This trial was launched a few years ago now when it was initially enrolling. And so in much of the world, PD-1 antibodies were not available. So ipilimumab, the CTLA-4 antibody, was the only one. And so the trial permitted people to have received that therapy, but most patients actually were enrolled treatment naive. So now, of course, our standards are changing. And so when we look at this outcome data, we become more and more interested in, well, how does this drug play following immune therapy, which is where we would anticipate it potentially having a role.